Hello everybody, welcome to this medical lecture series. In this medical lecture series, we'll discuss about challenges cases that you'll encounter in your daily clinical practice. And today we'll discuss about thyroid and pregnancy, hyperthyroidism in pregnancy. Before we discuss about hyperthyroidism in pregnancy, we have to discuss about human chorionic gonadotropin or HCG hormones, glycoprotein having both alpha and beta subunits. The alpha subunits are more commonly found in all glycoprotein hormones like luteinizing hormone, follicular stimulating hormone, and thyroid stimulating hormone. And the beta subunits are clinically very important because it has a specific specificity for its biological function, biological specificity. Then we'll discuss about transient gestational thyrotoxicosis. Transient gestational thyrotoxicosis develop in late first trimester pregnancy, and it is maybe due to high levels of HCG level. Sometimes you'll encounter inherited variants of gestational thyrotoxicosis which develop as a result of mutation in thyroid stimulating hormone receptor gene. And in case of early Graves' disease and transient gestational thyrotoxicosis may be difficult to differentiate the two. In this case, it's better to determine thyroid stimulating hormone receptor antibody, which will be elevated in case of early Graves' disease. When it comes to the treatment option, most cases, transient gestational thyrotoxicosis is self-limiting and doesn't need treatment. But if the patient develops overt thyrotoxicosis, the patient may need antithyroid drug. When it comes to Graves' disease during pregnancy, because hyperthyroidism may be associated with increased pregnancy loss and may have a serious medical complication for the mother and the baby. So it's better to diagnose early and treat. The true incidence of overactive thyroid gland is uncommon and accounting less than 2%. This is because the pregnancies tend to suppress the autoimmune response. Graves' disease is autoimmune disease because of the effect of the pregnancy in our immune system. Graves' disease is very rare, and also due to the immune effect initiated by the placenta, there will be fall in the thyroid autoantibody secretion during pregnancy, like thyroid peroxidase antibody, thyroglobulin antibody, and thyroid stimulating antibody. When it comes to the effect of thyroid antibody in the fetus, because the maternal antibody will cross the placenta, there will be a correlation between the maternal antibody level and the development of fetal thyrotoxicosis. If there is high levels of maternal antibody level, there will be high risk of fetal thyroid stimulation and the fetus may develop thyrotoxicosis. This fetal thyrotoxicosis is accounting an incidence around 1%, and high level of thyroid stimulating hormone antibody. That means antibody level greater than 3 times the upper normal limit of is usually correlated with fetal thyroid stimulation. When it comes to the diagnosing thyrotoxicosis in pregnancy is challenging because both pregnancy and thyrotoxicosis are accompanied by thyroid stimulation, hyperdynamic circulation, and hypermetabolism. And in addition to this, there will be elevated or increased level of thyroid binding globulin due to the estrogen-induced glycosylation. Because of that, the upper limits of T3 and T4 in pregnancy is 1.5 times higher than those in a pregnant mother. So biochemical diagnosis of thyrotoxicosis in pregnancy is confirmed by when the TSH level is below the trimester specific level. If you find TSH level below the trimester specific lower limit, you can diagnose biochemically thyrotoxicosis or Graves' disease in pregnancy. And the lower limits of serum TSH level in pregnancy is different in different trimesters. For example, in the first trimester it could be less than 0.06, and in the second and third trimesters it could be less than 0.3. Sometimes you can measure thyroid stimulating hormone receptor antibody, even though this antibody is less sensitive than in a pregnant mother. When it comes to the treatment option, treatment of thyrotoxicosis in pregnancy is challenging than diagnosing. So we have a lot of options of treatment. The first is antithyroid drug, the second is iodine and beta blocker, and the third is surgery. When it comes to the antithyroid drug in pregnancy, it is usually the usual methods of treatment in pregnancy and over treatment. In case of thyrotoxic treatment in pregnancy, over treatment is common than under treatment, and this should be avoided because the antithyroid drug given for the mother will clot the placenta and it will treat thyrotoxicosis or hyperthyroidism imposed in the fetus and the mother. We have to take care of when we are managing pregnant mother or thyrotoxic mother during pregnancy. When the drug crosses the placenta, the drug will overtreat the fetus and the mother. So the aim of the treatment during thyrotoxicosis treatment during pregnancy should be keeping the mother in the subclinical hyperthyroidism to prevent the fetal hypothyroidism. When it comes to the drug selection, the commonly drug during antithyroid drugs during pregnancy and both in pregnant and non-pregnant mother is thionamides, including PTU and metimazole. So both PTU and metimazole cause the placenta readily and locally. They will clot the placenta and they will have effect on the fetus. When it comes to the therapeutic effects or therapeutic antithyroid potency, both in metimazole and PTU, it is around 20 to 1. That means the patient needs 20 times higher drug dose of PTU than metimazole on prescribing drugs. Okay. For example, if the mother needs 50 milligram of PTU, that means the patient may need 2.5 milligram of metimazole. When it comes to drug selection during pregnancy, previously thought PTU should be the first line of treatment or the preferred drug during the all trimester of pregnancy. But even though this preference recently, because of the fatal but low, very low risk but fatal complication of PTU, like that's liver failure, it is recommended to use PTU in the first trimester when organogenesis is not completed, and metimazole is preferred in the second and third trimester. When it comes to drug selection, that means antithyroid drug. When it comes to drug selection and antithyroid drug, metimazole should be used in the second and third trimester, and near the delivery it's better to decrease or to hold antithyroid drugs because it may result in TSH-induced thyroid enlargement, and the baby may develop or the newborn may develop hypoxia due to TSH-induced enlargement of the thyroid gland. And the serum TSH level should be monitored mentally during antithyroid drug treatment in pregnancy. The other debate in treatments of hyperthyroidism in pregnancy is the place of block and replace regimen therapy. In adult, we can use, in the non-pregnant patient, we can use block and replace strategy. That means we can give antithyroid medication combined with thyroxine hormone. But in pregnant mother, this can result in severe fatal hypothyroidism because the drug may cross the placenta and higher level than the thyroxine hormone, so that is not recommended. When it comes to the side effects of antithyroid drug during pregnancy, the side effects are more common, or the danger is more common between 6 to 10 weeks of gestation when the organogenesis is in process. So the complication are aplasia cutis or defect in the scalp, abdominal wall defect, esophageal atresia, cardiac defect like ventricular septal defect, upper airway obstruction secondary to choanal atresia. That are some side effects of antithyroid drug during pregnancy. The second option of management is iodine and beta blocker. As you know, radioiodine therapy is contraindicated during pregnancy due to its risk of malignancy and teratogenic effect. But simple iodine can be used in the treatment option during pregnancy, but should be limited to less than 2 to 3 weeks because this thyroid can stimulate the fetal thyroid. Iodine will stimulate the fetal thyroid, and the fetus may develop goiter that can result in a period obstruction and in the entire life. The other option of management is beta blocker. Beta blocker is place of debate and use of beta blocker in pregnancy, because it can result in IUGR, depression. So that's the recommendation is to use beta blocker in a short period of time or in a very low dose. So you can use in a very low dose or in a short period of time during pregnancy. So the last option of management is surgery. As much as possible, major surgery should be avoided during pregnancy because it will have complications. It may result in major complications like fetal loss and thyrotoxicosis with thyroid storm. But if the surgery is needed, if the patient have contraindication for example, contraindication for anti-thyroid medication, if the patient needs high dose of anti-thyroid drug, surgery should be done in the second trimester. If the surgery is done in the third and first trimester, the first trimester there will be risk of fetal loss or abortion, and in the third trimester there will be preterm labor. So the surgery should be done in the second trimester. This is today's session, the end of today's session. In the next session we'll discuss about, or I will bring you other challenging thyroid problems that you'll encounter in your daily practice. Goodbye.